We start with the second session for the day. Renal stones, is liver the culprit? May I call on the presenter, Dr. Shivani Deswal, please. Moderator, Dr. John Mathai. Our panelists, Dr. Vinita Hardikar, Dr. Kumud Mehta, Dr. Anupam Sibal.
Yeah, let's start the presentation. Dr. Shivani is going to present a child with renal stones where the kidney wasn't the culprit, but the culprit was elsewhere. Shivani.
Good afternoon. The 13-year-old Sudanese boy presented to us with passage of small stones in the urine for past 6 years, generalized swelling and anuria for last 12 hours. However, there was no history of hematuria, dysuria or urinary tract infections in the past. There was no history of flank pains, polyuria or polydipsia. There was no history of excessive vitamin intake, bone pains or fractures. He was diagnosed in Sudan as end-stage kidney disease 1 year back and was on hemodialysis 3 times a week. He was a product of non-consanguineous marriage, third in birth order, with 2 siblings alive and healthy. There was no family history of renal stones.
Let's stop here. 1 second. Yep. What's the age of the child?
13 years.
13 years. So we have a 13-year-old child who's got kidney stones and has gone into renal failure by 11 years. So normally we don't find kidney failure by 11 years when there are renal stones. Can I have Madam commenting?
Ordinarily, unless the stones are obstructing and they are bilateral and they have been untreated, undetected, and they cause recurrent urinary tract infection, one doesn't. But in India, you know how it is. Sometimes
anything is possible.
Yeah, anything is possible. So if they're bilateral, I would think. But you are right in saying that they don't go into end-stage kidney disease. So one has to think of a metabolic cause of the kidney stones.
Yeah. I think that's the message from this case, that when a child comes with renal failure from kidney stones, and you really cannot find an obstructive component to it, think of the fact that there could be an underlying metabolic liver disease, metabolic disease. Anything from the audience? Any comments or questions to the panelists, or do we move on? Anybody else? Anupam, Vinita, any comments, or shall we move on? Yes, go ahead.
On examination, he had a height of 145 centimeters and weight of 29 kgs with a BMI of 13.8. He was pale, he was hypertensive, he had anasarca. However, per abdomen his liver was 2 centimeter with a span of 10 centimeter, which was normal, and there was no evidence of encephalopathy. There was no icterus. His X-ray KUB showed bilateral radiopaque shadows, and his ultrasound KUB showed hyperechoic lesions in the medulla and the kidneys, bilateral kidneys. It was suggestive of nephrocalcinosis.
Right. Would you like to comment on?
Yeah. This is definitely something to be taken very seriously, because there is nephrocalcinosis and nephrolithiasis. I think for the postgraduates, I would like to mention it's very important to distinguish one from the other. Because if there is a nephrocalcinosis, then there is a calcium deposition in the kidney tissue, parenchyma. And that's why more likely to have what is called tubulointerstitial disease and end-stage kidney disease. And of course, I should ask the PGs, I mean, they are very smart. What are the causes of nephrocalcinosis? Can anybody answer? There are only hardly 3 or 4 conditions, if I may.
Yeah, please go ahead. Yeah. They are always the target, yep.
Jaslow group.
Now you're going to go hospital-centric as well, so please prepare yourself.
Because we have done it many a times. Anyway.
Maybe the organizers can give a list of the postgraduates. They won't come in tomorrow.
I mean, just because of want of time, I could say that the common conditions are, of course, Barter's. Then you have distal renal tubular acidosis. Then you have also definitely, oxalosis as the cause. In fact, the nephrocalcinosis can occur right at the time of birth, very soon, within few weeks of life, and the stones may come later on. But these are the 3 or 4 things, and with the end-stage renal disease, I think one has to focus the investigative tests towards all the 3. I'm putting oxalosis last because it is comparatively a rarer disease compared to distal RTA and also compared to the other causes of nephrocalcinosis.
No, I'm surprised that the ultrasound had reported it so far only had as renal stones, because I'm certain that if this picture had come in by 11, there should have been nephrocalcinosis much
Yeah.
earlier on ultrasound. That probably it was a mistaken diagnosis.
That's right.
Any comments from the audience? Anybody has anything? Or we have a child who is, yes, diagnosed as renal stones but has nephrocalcinosis by 13 years and is already in renal failure, Anasaka, probably in bad renal failure, end-stage disease.
For the nephrocalcinosis can be either the fungal infections, also use of furosemide in the neonatal age group. That can also give nephrocalcinosis.
Yeah, but they are all transient and mild.
Yeah.
It doesn't progress. They are causes of nephrocalcinosis, but this obviously has progressed, so we wouldn't look at it. Yeah, Dr. Yacha?
Also comment on pancreas in this patient.
Pancreas
Not
was
that it is
normal.
there, but
Yes.
are there
Yes.
stones in the pancreas or not?
Right.
The reason is hyperparathyroidism
Yes.
can give rise to your pancreatic stones, can give your kidney stones also. Not that I am telling it is there,
Okay.
but you must mention.
Yes.
Yes, any other comments questions from the audience? Otherwise, let's move on.
Can I make a comment? Since I am the renal specialist, I
Yes,
thought
yes,
I
yes.
would. The commonest cause of the stones in our country is hypercalciuria, and hypercalciuria never causes nephrocalcinosis. So if you want to really, sort of look at it, that's not the cause one would think of in this.
Can we have this light off? Because I think they may not
We
be.
have such a glorious moderator, they keep shining it on you.
But you can't see probably the.
We need the
ultrasound.
light off, please. It's a little disruptive. Thank you.
Can we move on? Yep.
Shall I continue?
Yes, yes, go ahead.
His past investigation showed
Yeah.
a urine which was full of calcium oxalate crystals. The 24-hour urinary oxalate was higher than the upper limit, which was 180. Urinary oxalate by creatinine ratio was high. However, his spot calcium by creatinine and 24-hour urine calcium were normal.
No.
Right, I think that really brings up what Madam Dr. Mehta had just said, that the diagnosis is there. We put it 3 on the list basically because of the rarity of the condition rather than the fact that it wasn't excluded. Yes, any questions, El? I think the diagnosis is now straightforward. I think we've
Can I
already
make
got
a
the
comment
diagnosis.
here? Sorry
Yes,
to
yes.
disturb you again. Purely because there are calcium crystals in the urine does not mean that it is oxalate crystal does not mean that it is a case of hyperoxaluria. One has to do the investigation.
You still need to do a 24-hour urine
Yeah, you need
oxalate.
to.
I think that's a message from that you can find stray calcium oxalate crystals in the urine. That doesn't make it hyperoxalate.
His liver function tests were normal. Serum parathyroid and vitamin D levels were also normal. His blood urea was 70 with a creatinine of 3.5 and a GFR of 17. We thought the possibility of primary hyperoxaluria, and as ma'am said, we must confirm it. We got the plasma oxalate levels and the whole gene sequencing done from abroad, which was suggestive of primary hyperoxaluria type 1. We also did a bone marrow biopsy, which showed signs of systemic oxalosis in the form of oxalate crystals.
Shivani, why was the bone marrow done? Is there an indication to do a bone marrow or?
Actually, it was just to prove that it was, since in India we did not have the whole gene sequencing available and we had to send the samples abroad. So to make a diagnosis of another systemic involvement, we did a bone marrow biopsy which was feasible. But while the diagnostic is whole gene sequencing, which must be done before we confirm a case as primary hyperoxaluria.
Yeah, but I think the message is we don't really need a bone marrow to make a diagnosis.
This was because it was going to take us a couple of weeks. We also, as part of systemic oxalosis, wanted to rule out a cardiac condition. So we also
We did an echocardia. Yeah.
and we also did a CT angio to make sure that the coronaries
And what do
were
they
fine.
do? They do a special stain for oxalate or on the bone marrow? How do they make out? Any idea? Or?
So these are shiny refractile crystals which are fan-shaped, and primary hyperoxaluria calcium monohydrate crystals usually in the urine, and they are
in the bone
in the
marrow.
bone marrow they just radially oriented crystals which are fan-shaped.
Right. Okay, go ahead.
The child underwent SLED for 10 hours a day. He was started on antihypertensives, and a simultaneous liver kidney transplant was planned. Both the sisters willingly came forward. They were twin sisters. One donated the liver and the other the kidney.
Can I make a comment?
Yes.
Hyperoxaluria is a condition that is very broad. So primary is probably the rarest, but there's secondary, there's tertiary, there's hyperoxaluria, there's dietary, enteric.
Yes.
There are so many reasons for hyperoxaluria. So you had a gene test so you could make that diagnosis, and it was very likely because of the extensive disease at an early age. The second comment I have, and I don't know whether you're going to bring this up, is this doing both the transplants at the same time in somebody who you know is going to screw up their their kidney.
Yeah.
So why did you do that?
Yeah.
Yep. So I guess we can do the transplant bit
Yeah,
later.
bit later.
Yeah.
Let's
We are
move
coming to it.
Any question? Yeah.
Yeah, what I would have thought that this child has got a GFR of only 17. His CKD 4 going on 5. Is pretty bad, isn't it?
Yeah.
So what you're trying to do in the hemodialysis is you're trying to get the oxalate load away.
Yes.
So that, you know, then you
Absolutely.
can go ahead.
Yes.
Absolutely.
That I agree fully, but I think that whether he would, I don't know what's the outcome is after your liver transplant. We are too late in this particular child, if I may say so.
So I think we'll address those 3 or 4 questions about preemptive,
Hemodialysis,
sequential.
Would hemodialysis bring down the systemic levels of oxalate after a couple, or does it take many
it takes
sittings?
a pretty long time.
Yeah,
because
that's
you
what
know
I thought.
the oxalate which is produced in the body is to the tune of 4 to 8 millimoles per 1.73 meters square per day. And the hemodialysis removes only 1 to 2. So there is accumulation of the oxalate anyway. And if you really have to do it, you have to do every single day for 6 to 12 hours and do the night peritoneal dialysis. So it's terrible.
Right.
He was on intermittent hemodialysis 3 times a week, and when he came to us, we put him on a continuous daily dialysis of 10 hours a day. It was by the procedure of SLED, which is a modified form of dialysis, and kidney and liver donors were worked up, and their urinary oxalate levels were done, which were normal, and there was no suggestion of they being
the blood oxalate level is not a measure of the body oxalate level, isn't it? So what would be the best test that could tell us the systemic levels of oxalate?
Usually we do the urinary oxalate only most of the time.
But once the patient's got renal failure?
Yeah, that's the point. So, you know, it will not give you the correct answer.
So we really do not know how much oxalates are left in the system when you're actually taking a child up for a renal transplant or whatever.
That's
Yep,
right.
go ahead.
Can I start asking?
Yeah,
Primary hyperoxaluria is obviously autosomal recessive, and you're working up the siblings. My understanding was that heterozygotes also have an increased oxalate level, but I'll defer to the
That's
kidney
right.
specialist. Is that not right?
Yes, you are right.
I mean, and
So
these
even
ones, these ones, the levels were normal. So they might have been carriers, but I mean, the levels were normal.
That's what I'm saying.
Yeah.
The carriers have a higher level.
So the donor selection is very important
Yeah.
from that point of view, because you don't want to add more oxalate from the
Absolutely.
donor.
it's an autosomal recessive disorder, and the
So what are you saying, ma'am, that you would not have preferred the sister
Yeah.
to donate the kidney?
Yeah.
Okay, that's
It's an
the message.
autosomal, ma'am,
Yeah.
I would say that it's an autosomal recessive disorder. 25% of the siblings have the chance of being affected. 50% have the chance of being a carrier, while 25 have a chance of not having.
And she's 27 years old.
And she's 27 years old. She does not manifest renal stones,
Yeah,
neither calcium oxalates in the urine. So
But she had a 24-hour urine oxalate,
Yeah,
which was
she had-
normal.
yeah,
Yeah,
which was normal.
normal.
Yeah.
That's
Yeah.
more
Yeah.
important. Yes, you have checked it.
Yeah, go ahead.
Child underwent a simultaneous liver kidney transplant. He had on post-op day 2 bile leak in the drain, and re-exploration was done, and a duct-to-duct anastomosis was taken down, and hepatocoagulopathy was done. His sequential urine routine examinations were done, which were almost suggestive of no oxalate crystals. His renal biopsy showed extensive intraluminal and interstitial deposits of oxalate crystals. Pale bluish-white radially arranged laminated crystals were seen. Interstitium showed fibrosis. This is the child with his 2 sisters, post-liver transplant
They're
and
twins.
kidney
They're
transplant.
twins. One of
Twin
them
sisters.
is a doctor.
Just a point to make. Was genotype done? Because we must introduce this treatment of pyridoxine.
Yes, ma'am. Ma'am, he was given a trial of 3 months of pyridoxine, but he did not respond to it. And literature also says that only 10 to 30% of children with primary hyperoxaluria seem to respond. Though he was also given pyridoxine 1 month till post-transplant as well.
Yeah, but it was probably too late
it
in
was
the
too
day.
late
I think
anyway. But what I meant, if this child had come earlier,
much earlier, we could have tried
or
it.
his siblings, if you find, because that's very important. They are the ones who will benefit.
Yeah. So
Yes.
do you want to address those key questions that Vinita was raising now at this point in time?
Yeah, we can do it. But
Okay, so,
how
you know,
many
in-
more slides do we have?
Yeah, so this is the question: preemptive, simultaneous, or sequential. So
Yeah.
the ideal treatment is a preemptive liver transplant because we need to replace the enzyme. Now, when should we do a preemptive liver transplant? And that really is dependent on the kidney function. So if you've got a GFR of between 40 and 60, we might have had some improvement with pyridoxine. You put in a new liver, you might be able to prevent the kidney function for deteriorating. With the new liver, you might actually save the child a kidney transplant. Unfortunately, that doesn't really happen very often other than the very developed centers in the West where these conditions are picked up. So the vast majority...
So what would the message be for a child with a primary hyperoxaluria?
Yeah,
When would you...
It's important for the pediatrician and the team to talk to the family about a preemptive liver transplant because we'd be able to save the child a kidney transplant if this child is referred for a liver transplant earlier, when his GFR is say between 40, 60 or 50, 70, it kind of varies. But the vast majority will present later. Now you have a child with renal failure and we need to do a liver transplant and we need to do a kidney transplant. So the key question here is, should we do this simultaneously or sequentially?
One more question. Ma'am, what's the common age group when their GFR drops to 50 to 70 in a primary?
There is a lot of heterogeneity. You may have in the same family also, you may have an infantile oxalosis. That's the worst kind of a thing that you can have. But if you have an infant, even before the stones and all start, and is in renal failure and you don't find any cause, I think it's a good thing to do the biopsy and you can demonstrate the oxalate history. That's what we have done, but we had no opportunity of doing any liver transplant. Now this particular child may receive, if I may ask you, is a preemptive liver transplant. Because if the kidney functions are not bad at that stage, then you will supply the effective enzyme.
Yeah, but there's a heterogeneity in presentation. So there can't be an age group to say that this is the approximate age. You could need it at 1 or 2 years or maybe at 7 or 8 years.
So,
Girish.
I would never interrupt Madam Mehta.
No.
I have learned from her as a postgraduate student.
Thank you very much.
You're anyway British now, so you can't possibly interrupt anyway.
I hold a British passport, but I'm Indian at heart.
Oh, wow.
You go out of India, but
That's hurry up and make your comment, Girish.
No, the comment is that you do a preemptive liver transplant, completely support it, but it's not only the damage to the kidneys; it's just a dreadful systemic condition.
Girish can't hear you.
Oh, sorry.
I just request all of you to please be as close to the mic as possible. Vinita, you are very soft. We can't hear you.
Sorry.
I think I'll give you the mic. I'm very loud.
So what I wanted to stress is that you are preventing the dreadful systemic effects of the oxalosis, not only on the kidneys but the rest of the body, the heart, the vessels, which your PG student has stressed, is that then those are the things that you're trying to avoid. So if you see a child with primary hyperoxaluria, I think the best thing to do is to refer for a preemptive liver transplantation.
At what age, approximately?
As soon as possible.
As soon as possible.
Because you really want to prevent those systemic side effects, which are really, really dreadful when they happen. And the infantile hyperoxalosis are the worst ones that you see, with such bad bones and such bad vascular problems later on, that they are really, really difficult to manage.
Okay. Now coming to sequential versus simultaneous. Now that's where we are going to differ between India and the West. Now, if you look at the UNOS and you look at organ allocation, because the chances of a living related liver kidney transplant happening in a child, not very many centers overseas do it. So it is all dictated by allocation. And so a lot of this is going to be based on organ availability. Now, if we look at simultaneous versus sequential, what are the advantages of simultaneous? We all know that if you put in a liver along with a kidney, it is advantageous to the kidney because the liver is an immune privileged organ, as we see with liver intestinal combined transplants. So that's the advantage. You go through a major operation, you go through it once. You actually, if you are dealing in a child where you put in a liver and the kidney is really, really very badly damaged, and you have a child who's anuric, your liver outcome can get complicated by the anuria and all the kidney dysfunction that anyway happens after a liver transplant. So these are the problems. I mean, these are the advantages. The disadvantages, you know, it's a small belly. You have to put in a kidney as well after the liver, so you might not have size. You might not have a donor.
Technically.
So that might be an issue. So the Japanese tend to do a sequential, but if you look at, there isn't really a consensus. This is an area worth debating, simultaneous but sequential. But for us, it was relatively easy. This child had such severe kidney failure, had anuria. A liver transplant outcome would have been compromised. We had twins. They were willing to donate, there weren't any issues, and we were actually getting twins, so which means same blood group, so there was another added immune advantage. So for us it was relatively easy.
Relatively big child.
Yeah.
The child's about 13 years old.
Can I make a comment, please? I'll ask Anupam actually, that one of the problems with oxalosis, as Girish said, is that it's a systemic disease. So even when you replace the liver, you still have oxalate deposited entirely around the body, and the first thing that happens after the transplant is that the oxalate is mobilized and then kills the new kidney that you've just transplanted. So can I ask you to?
Yes, and that is one of the concerns. So it's really a risk in terms of, we'll give them maybe some pyridoxine, hopefully the liver works really well, there will be some amount of deposition in the kidney, but had you not done a simultaneous kidney with this child, have even pulled through after a liver transplant if he was so sick with anuria, you know. I mean, we all know the pressure that a kidney takes after a liver transplant. So really, honestly, there's no clear answer on that. It's debatable. In our case, it was easy because there was no choice. This child wouldn't have survived a liver transplant if he hadn't done a kidney.
I come back to that question I asked earlier. I mean, should we have done much more hemodialysis to
we did as much. We did. But, you know, a lot of this will still, it's hard. I mean, you know, we did, I think, about 2 weeks every day, you know, brought it as much down as we possibly could.
Then you put them on pyridoxine.
Yeah, no, we said post-transplant we'd put pyridoxine for a month as well. I mean, this has gone very well.
Maintained a good urine output for the initial post-op period so that there was no deposition in the new kidney.
Right. Can we just talk about pyridoxine for a minute? We're talking about like it's a magic pill. It doesn't work in all the patients, and it's a cofactor, isn't it, in that first enzymatic pathway. And it only works in people with certain mutations.
Yeah, absolutely.
That's the only thing we have.
Just throwing pyridoxine in.
No, absolutely.
It's a high dose pyridox.
Yeah, Dr. Yacha.
Yeah. See, whatever we are talking about the transplantation, what is your message to the pediatrician? Just tell them. It is not a question of preemptive transplantation. Question is how to recognize primary hyperoxaluria.
Early.
No, early is fine. If you find bilateral kidney stones, you are not finding any reason, you look for it. That is the time. Second thing, you have to clarify for the postgraduates. Why are you doing liver transplant? Not that I don't know.
Okay.
But I have got a slide on it. Clarify, why are you doing combined liver and kidney transplantation? There was an article in postgraduate, journal, and this was a patient, was an adult patient, where hyperoxaluria was there, but they had missed. They had done only kidney transplant, and thereafter this patient again came, he again developed problem, but actually they had missed, and then thereafter they did the liver transplant. So you have to magnify on that point, why are you doing combined liver and kidney transplantation for postgraduates? Rest of the discussion is wonderful.
Yep, you go to your...
Primary hyperoxaluria is an autosomal recessive disorder.
This is what you wanted. The
primary hyperoxaluria occurs due to deficiency of the hepatic enzyme alanine glyoxylate aminotransferase, which catalyzes the conversion of glyoxylate to glycine. And if this enzyme is absent, glyoxylate is converted into oxalate, and which accumulates along with calcium, and it forms calcium deposits in the kidneys as nephrocalcinosis, leading to obstructive uropathy and renal failure. It can also accumulate in the bones as metaphyseal bands seen on X-rays, in the hearts. That is when ECG and echocardiogram is very essential when we work up these patients, and vessels, peripheral as well as coronary arteries. And the other organs that can be affected are the thyroid, and the eye, the retina, and the optic atrophy can occur.
Go on to your carry home message. Yes.
Somebody wanted to, I'm glad Dr. Yacha is very, very, I think, sensitive about what message to give.
Do you have a carry home message in the end? You don't
You have a
take-home
message?
We will give a message.
Yeah. They just go to your...
I think you have a message? Please give.
No, she doesn't have a message. Yep.
I think I want to sensitize the pediatricians and the PGs. I want to make them realize that even if you have one single stone in a very young child, the child should not have even one single stone. I think try to, sort of do urinary auxiliate. I know it's difficult, the norms are not very well laid out and it's difficult to collect, but make an effort because at that time you can do a lot. The second thing is if recurrent stones, as in this particular child at a younger age, you must do auxiliate. Sometimes the mother says, no, nobody's doing the auxiliate. I said, I'll tell you where to do it and you can get it done. At least that is out of your mind. And you said about pyridoxine. Out of 5 cases that I'm treating, 3 are pyridoxine sensitive patients. I have not done the genotype. Maybe there is a difference in the African and Middle Eastern and Indian. I don't know.
I think the ones that I have seen also, they seem to respond to pyridoxine. That's really the reason why
she's on pyridoxine and she's not in kidney failure and she's about 7-8 years old.
Maybe our sort of genotype, about the message that you said, we really had 3 messages. The first one was, if you have a presentation which fits in with hyperoxaluria, please think of this diagnosis. You actually might save the child a kidney transplant. That's one. And the sooner that this diagnosis is made, the better it is from a long-term perspective. We all know that if you get a kidney transplant as it is, even if you don't have hyperoxaluria, you run the risk of a retransplant. So it isn't just a transplant once, but it's a question of need for repeated transplants. And the last message which I have to give, because otherwise my trip would be incomplete, is that 15 years ago, I mean, these 2 examples, or what Ashley will during the course of the day and a half talk about, these were all imaginary things in India. But as of September, we have now performed in India 455 liver transplants. And when we looked at the 7 centers that have done more than 10 transplants, we found that about 5% of the indications are for metabolic conditions in which there is no liver failure. And I think that just goes to prove that how the spectrum has expanded. So it's not just about biliary atresia, acute liver failure, hepatocellular carcinoma, and Wilson's, and so on and so forth. But it's for conditions like Klippner-Meyer, it's for conditions like hyperoxaluria, it's for other metabolic conditions as well. And I think that is very positive, and that gives hope to patients with a variety of conditions that had no hope 15 years ago.
Thank you very much. Thank you for the good presentation. Thanks to Vinita, Anupam and Madam for the participation. Thank you.